So welcome all who are just joining us for the evening session. Kindly, if you can write in the chat box which country you're from, we'll really appreciate it as we wait for a few minutes before we start the session. I see Namibia. All right, some people from Nigeria, Lagos, and Ibadan. That is Omuwumi and Dr. Solomon, Dr. Adeparusi as well. Welcome. Dr. Shah from Kenya, Dr. Gupta from Chennai, India. Oh, we have Dr. Aisha Al-Sharif from Saudi Arabia. Dr. Kezagule, that was my classmate. Welcome, surgeon. Dr. Okonko from Port Harcourt in Nigeria. Welcome. Dr. Nagaraj from Shabitha, India. Welcome. Dr. Nihala from India, welcome. So we'll just have about 5 more minutes just to allow more members to join, then we start. Keep filling in the chat box, at least to know the reach. So far we have participants from Kenya, India, and Nigeria. So the more the merrier. We will start at exactly, in exactly 1 minute. Dr. Minesh from Nairobi, Dr. Ogordi from Nigeria, greetings. All right, so we are good to go. We'll start the session. My name is Dr. Elvis Mutai. I'll be one of the moderators today. I will be introducing this panelist, group of panelists that are joining us from India. And before we start, we would like to thank you all for coming in for this conversation that we've been having. This is the 3rd session in the month from Kenya Association of Pediatric Dentists that we are doing specialized care for dental patients. We, of course, welcome a multi-practice approach to this care because these are patients that require a lot of attention and special attention that will veer off the routine and day-to-day practice. And we encourage ourselves and the medical practitioners to at least collaborate in this regard. We also encourage the local and international groups to join the Kenya Association of Pediatric Dentists, and this normally has a membership fee of roughly 5,000 shillings for doctors and 4,000 shillings for students. By students, this includes the undergrads and not the postgraduate students because it's already qualified doctors, so don't hope for a discount there. We also are open to medics and even whatever level of study that you have achieved, whether it's PhD all the way. We welcome you because of the kind of knowledge we hope to spread. Today we're expecting, and we have so far seen participants from Kenya, India, Nigeria. We're expecting some from Ghana and Tanzania, Zimbabwe, Egypt, as well as South Africa. And please keep filling in the chat box just to show the kind of reach we have. So far, we have quite a number of participants, over 100. We are working in collaboration with the Federation of Specialist Care Dentistry and the Kenya Association of Pediatric Dentistry to bring you these presentations. We will award CPD points for the Kenyan team that will have registered for this particular presentation today. We are going to be working with Dr. Manesh Lahori. You can see his qualifications there. He will be the moderator during the time the speakers are having their presentations. Kindly share your questions. We will be answering them at the end of the presentations, just so that we don't have any interruptions and we have good flow. So Dr. Manesh Lahori is, as you can see his qualifications there, graduated with the BDS in '96 from A.B. Shetty College, Dental College and Hospital. He is Director, Principal and Dean, KD Dental College Hospital in Mathura. He is Professor and Head of Department of Prosthodontics of KD Dental College and Hospital in Mathura, Vice President and founder member as well of Uttar Pradesh Prosthodontic Society, past president of Uttar Pradesh Prosthodontic Society, founder member, Academy of Oral Implantology in New Delhi, past president, Academy of Oral Implantology in New Delhi as well, fellow of the India Association of Oral Implantology, fellow of International Congress of Implantology, diplomate, Academy of Oral Implantology. So he's not only avid academician, he's also an editor of Guidant India, associate editor, Journal of Indian Prosthodontic Society, assistant editor, International Journal of Oral Implantology and Clinical Research. He's been active in academia for the past 20 years, and he is very instrumental in conducting dental camps. So he's not only an academic, but also a philanthropist in the rural population of where he comes from in Mathura district. I will hand over to him now so that he can take over the presentations. Welcome, Dr. Manish.
Thank you, Dr. Elvis, for the lovely words, and good evening, everyone, and a warm welcome to all the delegates across the globe. I welcome you to this third session of an initiative by the Kenya Association of Pediatric Dentists and Federation of Special Care Dentists. We have two renowned speakers today, Dr. Puja Grover and Dr. Priya Verma, who will be shedding light on the perplexing dilemma of handling patients with epilepsy. Dr. Puja Grover will be throwing light on recognizing seizures and management, while Dr. Priya Verma will be talking on epilepsy and dental management. So our first speaker is Dr. Puja Grover. So before I hand over the session to Dr. Puja Grover, I'd like to introduce Dr. Puja Grover. She's a consultant pediatric neurologist with two renowned hospitals in Delhi. Dr. Puja Kapoor has done fellowship in pediatric neurology from Jaslok Hospital, Mumbai, and fellowship in electrophysiology from Cleveland, U.S.A, and her D.N.B from Chittaram Hospital, Indore. She has numerous publications to her credit in both national and international journals. She is the reviewer of the index journal Indian Pediatrics. She has won the scholarship for higher studies from Tata Trust and Mumbai Hospital, Mumbai. She is the co-founder and director of CONTINUA Kids, which stands for Center of Neurotherapy in Uniquely Abled Kids. Established in 2016, this therapeutic center has catered to the needs of more than 7,000 plus special needs children. CONTINUA Kids has 9 branches in Delhi, NCR, and plans to spread till every special needs kid needs are met with. This mission of CONTINUA is to be a social equalizer and nurture the latent talents of the special needs children. She is attached to various NGOs like Khushbu Welfare Society and supporting children of special needs. She has special interest in developmental disorders like autism and attention deficit hyperactivity disorder, and is dedicatedly working to the inclusiveness of these children. I welcome you, Dr. Puja, and session is all yours.
Thank you so much, sir, for this warm welcome. And thank you everyone for giving me this platform to have a word with you all and share and communicate with you what pediatric neurology, epilepsy, and how to manage these all. So without wasting much time, I will start with my presentation, which is on epilepsy, how to diagnose and how to manage it. So let me just share my screen. Yes. Yes. So am I audible as well as my screen is visible? Should I start?
Yes, very much.
Okay.
Yes,
Thank
please
you.
go ahead.
Yeah. So very warm evening to all, and let me start with the topic. So epilepsy, recognizing the seizure and how it has to be managed. So before starting, let us define what epilepsy is. So before 2017, International League Against Epilepsy had different guidelines, but after 2017, these guidelines were put in, and those are: you have at least 2 unprovoked seizures which are occurring more than 24 hours apart. That means there should be 2 seizures to label it as epilepsy. One seizure will not be defined as an epilepsy. Second, it has to be unprovoked seizure. We will just discuss what do you mean by unprovoked seizure. Also, it has to be more than 24 hours apart. If you have a seizure and suppose in next hour you have another seizure, that would be considered as a single seizure and not as 2 seizures. So you have to have 2 seizures which are more than 24 hours apart and have to be unprovoked to be labeled as epilepsy. So before 2017, that was the only recommendation which we had. But after 2017, they have put in 2 other conditions which would be defined as epilepsy. The second one is if you have 1 unprovoked seizure, that means without any provoking factor, you have 1 seizure, but you have a very high chance of recurring of seizure. That means at least 60% chance of having a second seizure. Maybe you have some malformation in the brain, you have some trauma to the brain which has left down some scarring to the brain. Because of that, you have very high recurrence chance. Then also, in spite of having just 1 unprovoked seizure, you could label it as epilepsy. Previously, this was not there. Now they have included this because they found out that if you have an inciting factor in the form of any structural malformation or you have some gliosis from the previous trauma, you have very high chances of having another seizure. And so you could be very well be labeled as an epileptic person. Third is, in a special age group of pediatric, we have certain age-related epilepsies which start at specific age and end at specific age. They have very, very much clear characteristic in their symptomatology and in their semiology. And because of that, they are called as pediatric epilepsy syndrome. So once you figure out that this child could have epilepsy syndrome, which is particular semiology, you could very well label it as an epilepsy. So after we define that, okay, this is how epilepsy could be defined, we'll move on to what do you mean by unprovoked seizure. Suppose you have a child has a fever and then because of fever he throws a seizure, that won't be called as a unprovoked seizure, because there was certain temporary reversible thing which led the child to have a seizure, and because of that provoking factor the child had seizure. So that won't be called or labeled as an unprovoked seizure. To have an unprovoked seizure, you have to have something substantial, something permanent, something non-reversible in the brain to cause an unprovoked seizure. Like for example, you can have a trauma to the brain So, and which could later, after few years, give rise to some gliosis of the brain leading to seizure. That would be called as unprovoked seizure. But suppose you have a fall, and because of that fall and because of that trauma, for a while you threw a seizure, that won't be called as a unprovoked seizure, because it was the trauma, mild trauma, which led to maybe dizziness or some syncopal thing, and you threw a seizure. So that would be a temporary thing, and in that case it would be just called as a provoked seizure. So in the definition of epilepsy, that won't be counted. So now, after we have defined that this is epilepsy, we need to know what kind of epilepsy is there. We have to subcategorize the epilepsy. Why we have to subcategorize is because there are certain anti-epileptic which works on focal seizures. There are certain epileptics which works on generalized seizure, that too with tonic type, that too with atypical type. So you need to have the semiology and subtyping of the seizure to find out which anti-epileptic would suit my child. So we want to define it into 4 major categories. One is focal. Focal means you have only one part of the body which is showing the part showing seizure. Second is generalized onset. At the start of the seizure, you have the whole body which is seizing. Then you have unknown onset. Suppose the child was seizing before and you came in much later and you don't know whether it started from right side and then it spread to left side and then it went through the whole body. So in that case, you just label it as unknown onset. And the 4th category is unclassified, because there is no adequate information from the clinical history, neither you are able to get some video of the child. So then you can label it as unclassified, which could be later classified into other types depending on how you get the history. So there are focal, generalized, unknown onset, and unclassified. So after you have categorized the focal onset, you should need to know whether the child, after having an focal onset, the child is aware or is unconscious. That means his impairment, he is impaired in his awareness. So then after you categorize, then you classify the type of seizure. I know it will be appearing out a lot to you, but I will show you videos and then again come back to this classification so that it makes sense and it become more easier for you to understand. So let's go to the videos and find out what type, and then we'll come back again to this classification. Why I'm pressing so much on this classification is because until and unless you don't know what type of epilepsy is, you won't be able to decide on a good anti-epileptic. So let's go to the video. So if you look at this video, this is a newborn child who's hardly 7-day-old, and you could see both his upper limbs are totally stretching and his body is becoming like an arch, like a bow. So, and throughout the period he is doing like this. Both his arms are stretched like that and the body is making a curvature sort of thing. So basically this is a tonic seizure. So you classify it because whole of the body is involved. So it is a generalized seizure. Second, out of the generalized seizure, which type it is? It is tonic, because the whole tone is increased. The body tone is increased and the child is stiff. So let's go back to the classification and see. So where we are, the onset was generalized because whole of the body was involved. Out of this, once we have classified this, so it was a motor seizure. That means the body parts, the limbs are involved, showing some movement. And what kind of movement? It is a tonic seizure. Tonic means the whole of the body tone is constantly increased for a while. So we would be able to know this is a generalized onset with motor seizure, which is a tonic type. So let's get back to the seizure once more, and so you will be able to get into the thing what I'm talking about. So the body tone is increased, it's a generalized thing, and it's a motor thing. So I think I've made sense. Let's move to the other video. So in this video, what was there that the child has, this is an adolescent person. So this boy, if you see at the eyes of the child, the eyes are rotating like this. His head is turned toward one side. His consciousness is well prepared. He's talking to his mother. And let me play the video once more. You could also see there was some movement of the chin too. So there was movement of the eyes, there was movement, constant, some twitching movement of the chin, and also he is conscious. So let's see it once more. Also, you won't be able to appreciate, but his left limb was also having some movement, but it's not so clear in the video. So this movement was focal. It was not generalized. The whole of the body was not involved. Only the part of the eyes, the chin was moving towards left side. There was some movement of the left hand too. And the child consciousness is well preserved. So let's move back to the thing. So it was a focal onset seizure where impairment, there's no impairment of the awareness, and it is a motor type because there is some movement of the limb and the eyes, and this is clonic type. The movement which you saw was clonic because it was coming and going. It was coming and going. It was not like toning, which was a constant, sustained movement. Okay? So let's go to the third video. So if you see at this video, this is a child 5-6 years old, and if you look at it, it's the whole body which is involved. That means it is generalized type of seizure. Second, there is not a constant sustained tonic posturing. It is like the eyes are blinking like in the above case. So this is clonic movement. There's twitching, there's coming back, there's twitching, this is coming back. So this is a clonic movement. This is a generalized type of seizure. So if we go back and look at the classification, we will see that we fall into the category of, if you want to categorize the seizure, it is a generalized type, it is a motor movement, and this is a clonic movement. So we have generalized, motor, and clonic. So let's go to another movement. I wish if we could write down if you have understood. I'll show the video, and if you could put something in the chat box if you have understood something. I'm not going to tell you the diagnosis. Tell me if you have understood. I'll show you the video. Put your comments in the chat box and we will discuss on that.
Gundu? Hey, Gundu. Gundu? Hey.
So I'll give you the history. This is 2-year-old child whose left hand is moving like this. So you have to tell, only the left hand is showing the movement, rest the child is sleeping well. So anybody would like to comment? I'll wait for 1 to 2 seconds for the comments. What type of seizure do you think this child has? Generalized, focal, clonic? Yeah, perfect. So I think I made sense, and I have a very elite audience because most of the answers are all right. So this is a clonic movement, and also you have to say this is a focal clonic movement. If you go to the start of the thing, to start with, it is a clonic movement, but before that we have to tell it has got a focal onset because it was only left-sided. So focal onset, I don't know whether the child is aware or impaired awareness because the child is sleeping. So I don't know much about this. It has a motor onset and definitely this is clonic. Great. So let's move to other video, and again to make it more interactive, I would like your suggestions in this. So yes, I got the reply. If you have replied, generalized, clonic, and impaired awareness. So it's generalized tonic, generalized clonic. Okay, so this is here. This is not a clonic seizure. If you go to the previous video, there was the clonic movement was like a constant twitching which was happening like this. Whereas if you see, the child just drops like this, comes back again, drops like this, comes back again. The frequency as well as the amplitude is totally different from the clonic seizure which I showed you before. So definitely this is a generalized seizure. Without doubt, this is a generalized one because whole of the body is involving the limbs too. But this is not a clonic seizure. This is a epileptic spasm. So we'll go to the classification once more and see. So it is definitely a generalized onset. I agree. A lot of people have read it as clearly stated it as generalized. I agree to that. It is motor because limb movements are involved, but it is not clonic nor tonic because there was sudden fall. The child used to get up and then there was again after a few seconds there was a fall. So this is very classically myoclonic. Or you can say it as epileptic spasm. So the difference between myoclonic and epileptic spasm is just for few milliseconds, but for all practical purpose, let's keep it both. I'm putting up the whole of the category as one, and if you want to be very precise, then it is like epileptic spasm. What do you mean by epileptic spasm, which I showed? So child is absolutely fine. Then there was he just goes like this, loses his balance, come back again, then again there's a spasm, come back again, and whereas in clonic, these are very high in frequency. I'll show you once more. So this is clonic. So whereas in this is again clonic. But this is epileptic spasm, or you can say it myoclonic too. The child is all right, very well. Thank you. And then there's a spasm. The child is absolutely fine, and then there's again a spasm. So this is epileptic spasm. So let's go to the other slide.
Chiu. A good look. Chiu.
Sorry.
Chiu. Chiu देखो मम्मा. Chia. Chiu.
So
Chia.
any suggestions or any views on this type of seizure? So if you look at it clearly, the child is sitting comfortably and then there are small spasms. I'll show you once more. So the mouth opens, there's a small jerk which comes in. The mouth again opens, the child relaxes. Then again there's a seizure. The child goes back. Again there's a seizure. Again, but the frequency is not the same as that of clonic. In clonic, the frequency was much higher. Here, the child seizes, stops, seizes, stops, seizes, stops. So this is again epileptic spasm, like the previous one. Why? Because there, it was the whole body which was very persistently and very aggressively moving. Over here, these are smaller jerks, but these are the same as that of the previous one, but there the intensity was very high. Over here the child has small jerks, but those again are appreciable, and the semiology, the frequency is more than the previous slide, but definitely this is not matching the type of clonic. This is again the epileptic spasm. Why this is very, very important? Because these are very well missed. These are the most dangerous type of epilepsies that requires steroids, very, very high doses of steroid to get better. And these are the one which later on can again give rise to other type of epilepsies. And if not dealt at a very early stage, they can have long-lasting impact on the child throughout life in the form of cognition, in the form of speech. So if you see these type of seizures, those are the most dreadful, very difficult to be treated, and have a very long, bad side effects if they are left untreated. Both on the cognition, both on the language, both on the normal development, both on the behavior. So let's get to the other one. So, before 2017, there was a lot of confusion, and we were like, there are certain epilepsies which are benign. There are certain epilepsies by which we don't know the cause. But a lot of confusion has been eradicated by a lot of genetics which have come in a big way. And we know all those things which was previously called as idiopathic are now called as genetic. We are getting a lot of genetics which are done in these children, and we are getting high level of positive reports which tell us that if the semiology is like this, then the genetics would be like this. And previously, which were termed as idiopathic, we were not knowing the cause, are now coming up in our genetic reports. So now the idiopathic term has been replaced by genetic. Previously, which were called as symptomatic, that means because of some concerns in the brain, maybe some structural malformation, maybe some other thing, maybe some trauma or after, now they have been labeled up as structural and metabolic. Those are not called as symptomatic. Those are called, you have to define now. With the with progression of science, we are able to define and find out the cause much more in a specific way. And previously they were very vague terms which were given, and now we are defining up in a very clear-cut guidelines in a very much good way, so that we will able to find out the etiologies and work accordingly. So now, obviously previously there was something called as cryptogenic, which we were not knowing, and where we have labeled as unknown cause. And maybe later, if you do the workup, you could find out some genetic cause, some structural cause, or some metabolic cause after you do a lot of workup, maybe in the form of genetics, maybe in the form of PET scans, maybe in the form of good MRIs, high 3 Tesla MRIs, maybe in the form of digital diffusion weighted images. So a lot has been done, and it helps us to find out and delineate the etiology in a better way. Let's go to the next slide. It's not moving. Yeah. So after we have found out what type of seizure which it is, then we have to find out what type of epilepsy it is, because that helps a lot of prognostication. Where are we going to land? And also, if we know that these are specific age-related epilepsies and fit into certain types of syndromes, then we have to label it as a syndromic form. Out of the causes, you also have to define the cause, because causes helps us to find out what the prognostication is, how we have to treat the thing. And so to know the causes, it could be any structural cause, any genetic cause, any infection, maybe in the form of meningitis, any metabolic causes, immune, and if you are not able to delineate the cause, then you label it as unknown. Also, you have to know the associated comorbidities which are there, because then only you will be able to define it much better and will be able to find out which anti-epileptic has to be used. So what are the tests which you should do, which are there at your disposal? It all depends on what are you suspecting. Suppose you are suspecting that my child could have a tumor, then you should go in for a magnetic resonance imaging or an MRI brain, which should be 3 Tesla. That's the power of the MRI brain to define the structure which are there. Also, it should be associated with different technologies which are there in MRI, like diffusion weighted MRIs, like SWI. So these are the types of imaging which are there in an MRI, which helps us to delineate what type of tumor it is, what could be the prognosticating factors, and this would really help us in the long-term outcome of those child. Similarly, if you expect there's a child who presents with fever and seizures, then you should go in for an MRI brain along with lumbar puncture to find out how much infection it is there, which type of organism it is there, and then what type of antibiotics you have to use, or antifungal or antiprotozoan or whatever you have to use. Similarly, if you find that the child has very typical semiology of a childhood syndrome, then you should just do an EEG and you would be able to find out what kind of syndrome it is. So depending on what kind of the child shows the scenario, you can choose and find out and select the types of tests which are there. Also, now they have once you have an epilepsy, you are never said to have cured epilepsy. It is always resolved epilepsy. There's no terminology as cure, because there are chances that maybe in your lifetime you can have a precipitation and again you can throw a seizure. So what do you mean by resolved epilepsy or free from epilepsy? If you are seizure free from next 10 years, and also you are not on any medication from last 5 years, then only you would be called as to have a resolved epilepsy. And also now they have differentiated and called it as a disease rather than a disorder. Previously, it was called a seizure disorder. Now they say this is not a disorder. This is a very substantial thing, and you can have very grave consequences later in your life. That's why they have removed the word disorder, and now epilepsy is called a disease. Now, once you know what type of an epilepsy it is, you have to find out what type of anti-epileptics we have to use. So to find out which anti-epileptics we have to use, there are certain specifications like which type of epilepsy. Suppose you have a generalized epilepsy, there are certain medications which are used for generalized. There are certain medications which are used for myoclonic. So you have to have an epilepsy defined. If you give an anti-epileptic which is there not defined for myoclonic, it might precipitate myoclonic epilepsy more. So if you give something as if you give something like in myoclonic seizure, if you give carbamazepine, it can precipitate more of myoclonic seizure. If you give Sabril, then it will precipitate more of myoclonic seizure. Similarly, you should know the dose-dependent adverse effect. Everyone has a ceiling dose. You should not go beyond that dose. Also, you should know the idiosyncratic reactions which can appear with any type of anti-epileptic. Then you should know the pharmacokinetics. Similarly, you have to have an age definition, because there are certain epileptic like valparin which you cannot give in a newborn child. There are valparin you cannot give to a female adolescent girl because it can land up into PCOD. So there are certain medication which you should not combine, like you cannot combine very high doses of valparin along with lamotrigine. It can cause Stevens-Johnson syndrome and various type of liver failures and things like that. So to define, you have to know which kind of epilepsy it is. There are certain specifications for the age, there are certain specifications for genders, there are certain specifications for co-medications. So you should know all this before you define the anti-epileptic. So suppose now you have defined what type of anti-epileptic you can give. So for generalized tonic clonic seizure, the latest recommendation is that you can give the treatment of choice is topiramate or valparin. Also, you can give phenobarbital. Apart from this you should not give because this can precipitate. So phenobarbital, topiramate, and valparin for generalized tonic-clonic epilepsies. If you have partial epilepsies, that means focal epilepsies, then you can give carbamazepine. Carbamazepine is the drug of choice for focal epilepsies. Then you can also give phenobarbital, phenytoin, topiramate, and valparin. If you have absence epilepsies, then you can give ethosuximide, lamotrigine, and valparin. And suppose you have myoclonic epilepsies, then the drug of choice is clonazepam, levetiracetam, topiramate, valparin, and zonisamide. So I know this is very difficult to remember, but you can take the screenshots and learn it later on. So once you have defined, you have to also decide the dose. So this is how the dose curve moves. So at a very certain low level of anti-epileptic to start with, you are there in this zone, and this is the therapeutic zone. Until and unless you are not in this therapeutic zone, the anti-epileptic is not going to work. And that's why you should know what is the half-life of the anti-epileptic, after how many hours the child will start showing the result, and what is for how long this is going to act for last. Suppose if you give clonazepam, which has got a half-life of 18 hours, you know that, okay, once daily dosing would be fine. Suppose you have to give valparin, which have a half-life between 8 to 10 hours, you know that every 12 hourly you have to give this. So depending on the half-life of the anti-epileptic, you should know the dosing would be. There are certain things which are different from the adults, like in neonate, you have to give lower doses per kg because they have very low protein binding, leading to high toxicity. And also they have low metabolic rate, which can again give rise to toxicity. Similarly, if you go for children, you have to give higher doses because they have very fast metabolism as compared to adults. So to start with an anti-epileptic history, We started with the first anti-epileptic in 1857, and we have come down to, after 2009 also there are anti-epileptics, but these are all the anti-epileptics which we have invented and discovered. And out of that, there are few which are used a lot in the form of valproate, clonazepam, carbamazepine, which have got the best results and low side effects. Also, you should know how these anti-epileptics work. So these anti-epileptics works on the sodium channels, calcium channels, hydrogen channels, glutamate receptor channels, GABA channels, and carbonic anhydrase inhibitions. So why this is important to know is because if we know that I am giving valparin which works on sodium and calcium channel, so I won't give an anti-epileptic again which works on the same channels if the seizures are not controlled. I should give something which acts on other channels so that it has a synergistic effect and act in a good way for the better control of the epilepsy. So this slide is important for all the dental people. Why? Because the adverse effect of the orofacial reactions, xerostomia is one which you should be very much interested in. So a lot of all anti-epileptic basically cause xerostomia apart for phenytoin and primidone. If you look at, and also if you look at carbamazepine, it causes xerostomia, phenobarbital, valproic acid, gabapentin, all, if you look at all of the anti-epileptics, all of them give rise to xerostomia, because xerostomia causes dryness, and because of that you can have more dental caries and a lot of issues of the mouth. Similarly, stomatitis, gingivitis, and glossitis. So these things are also very important to know for a dental viewpoint. So carbamazepine is the culprit, and again phenobarbital, primidone, and valproic acid. So also I would like to tell that phenytoin is one which causes a lot of gingival hyperplasia, and also valproic acid is again one medicine which causes a lot of gingival hyperplasia. You should always know about idiosyncratic, because it can happen in anybody without any known cause. And Stevens-Johnson syndrome is one thing which you should know. Rash appears first, and it can give rise to this kind of picture. So there's whole rash all over the body, and this adult was given basically carbamazepine. So there are certain medication which can give rise to Stevens-Johnson syndrome, rash like this, and the most famous ones are Eptoin, that is phenytoin and carbamazepine. And also if you give lamotrigine along with valproic acid in high doses, you can line up into Stevens-Johnson syndrome. This is what you call as gingival hyperplasia, which was induced by phenytoin. You are not able to see even a single tooth. It is all gingival hyperplasia which has covered whole of the mouth. Once you stopped it, it starts regressing. So it is like reversible change. And long-term effect, again, a lot which we should be interested in is like gingival hyperplasia, hirsutism, and growth. That means the facial coarsening is again phenytoin and phenobarbital. So we should know these medicines, and you should stop this if you have any of these side effects. Apart from this, I don't know whether I should describe, it's not of much interest. Now, this is very interesting because you can have a status epilepticus when you are doing a dental procedure, and you should know how to stop it. So the definition is a brief seizure is which is less than 5 minutes, a prolonged seizure is 5 to 30 minutes, and once you got a status, if it is more than 30 minutes. But there is a catch in that. Any child who comes to you seizing, irrespective of the time which it started, has to be termed as status, because you don't know the time how much it from before he was seizing. So once the child reaches the hospital and seizing, you should term it as status epilepticus. In fact, if the child proceeds more than 5 minutes, you should start treating it as status epilepticus, because once you reach 30 minutes, you are left with nothing. So any child who starts seizing on your dental table, take it as status and start treating as status epilepticus. So you can have convulsive status epilepticus like the generalized seizure, which I had shown you before. The child would start seizing once on the dental table, and that could be a generalized clonic seizure, generalized tonic-clonic seizure, generalized myoclonic seizure. Anything could land up, and that could be the type of status. You can also have partial status. That means one side of the body is seizing. So that I've already shown in the video. So the cause could be anything. You can have any intoxication because of infections. You can have any post-traumatic cause which starts seizing at your table. Any stroke which was happened before and the seizure started at your table. You could have true tumors. You can have n number of causes which could precipitate in a seizure. So I'm not going to go in this because there's a lot of neurology. This slide is very, very important, because this is going to help you to deal with what to do when a child who's on your table starts seizing. So the most important thing is A, B, and C: airway, breathing, and circulation. Check down, there is nothing in the airway passage. The child is breathing well. If the tongue has gone back, try to bring the tongue down. See if the breathing is there. Check for the pulse if the circulation is there. After you have done these three things, go for a benzodiazepine. So before the invention of benzodiazepines, a lot of barbiturates were used, but now benzodiazepine is the drug of choice for the instant treatment for status epilepticus. You can use midazolam, which can be given intramuscular. If you don't have any access to IV, you can give directly intramuscular midazolam. You should have in your clinics this medication, and you can give like 10 milligram if it's the 40 kg and 5 milligram if it's less than 40 kg. Or you can intravenous lorazepam. I don't know whether you would be having access to intravenous, but then for the journal purposes, you should know that intravenous lorazepam can be given 0.1 milligram per kg. Also, you can give diazepam, which have the equivalent result. The most important thing is that if you don't know how to give intramuscular, you don't have an IV access or a trained staff to put an IV, you should have a intranasal midazolam in your clinics always. And this is what I'm going to lay a stress on, because it has been found, and studies have proven time and again that intranasal midazolam is as equivalent as intramuscular midazolam, is as equivalent as intravenous lorazepam, is as equivalent as intravenous diazepam. So also, if you don't have this, you can also use rectal diazepam, but that is way back. And now if you have intranasal midazolam, there's no need to go rectal diazepam. Now, this is how you have to give. It comes in a bottle form. 1 puff is equal to 0.5 milligram of midazolam. Also, 1 puff could be 1.25 milligram of midazolam. So you should always have these two varieties: 0.5 milligram puff for smaller children, 1.25 milligram per puff for adult children where you require a high dosing, and the dosing is 0.1 milligram per kg. So if a child has got like 6 kg suppose, then I have to give 0.6 milligram. So 1 puff has 0.5 milligram, so I have to give 1 puff. Suppose the seizure doesn't stop there, you can repeat the dose once more. So this is how you have to use it. Shake the bottle gently, remove the protective cap, and with your fingers like this, you can press it. And once you press the nozzle, there would be a jet, and the spray, it has to be given in the nose, intranasally in the nostrils, like this. You put the puff, put the nozzle in the nose, in the nostril, and then press it, and there would be a spray. The spray would be 1 puff, which is equivalent to 0.5 milligram of per puff. And also, you don't have to put the child in the lying position. It has to be like 30-degree upright position for the spray to act active. And then you can also block the nose so that it doesn't fall down and it's well absorbed. And you can repeat the dosing if the seizure doesn't stop. So this is what all the studies tell, which I was telling before, that IV lorazepam, IV diazepam has the same result as rectal diazepam, intramuscular midazolam, and intranasal midazolam, buccal midazolam. Suppose the child who has got rhinorrhea and he has a running nose and you don't know how to put it, where to put it, you can also use buccal midazolam. You can just open the mouth of the child and in the mucosa, you can just put this spray. It is as equivalent as intranasal. So, and also right now we are working on sublingual lorazepam and rectal lorazepam, but not much have been proved. But intramuscular midazolam and intranasal midazolam has the same efficacy. Similarly, for the second line medication, I don't think that you require second line medication, but just for the sake of putting it, that intravenous valproic acid has better tolerability and could be used as the second line of medication. Suppose you have given the required doses and the seizures are not stopping, then you have to have an IV intravenous access, and you can put valproic acid or phenobarbital, whatever is available to you. Now coming to the side effect, why it is important, because if you're putting midazolam in nose, what you should expect to happen, respiratory depression is the most commonest clinically significant side effect which could happen, and you should know about it. Suppose you have given first dose of the antiepileptic, the seizures have stopped, and you should always check in for the respiratory rate, because respiratory depression is one thing you can land up if you give a lot of doses in the OPD setting. So you should know that you have to give less dose, very required dosing, and more dosing can give rise to respiratory depression. And that is all I have. And I think I pass the thing to Dr. Manish.
Thank you, Dr. Puja, for a wonderful insight into recognizing seizures, and accordingly the treatment could be rendered. Thank you so much, and we'll have the question answers at the end of session. So we'd like to introduce our next speaker for the evening. She is Dr. Priya Verma. And before I hand over the session to Dr. Priya, I'd like to introduce Dr. Priya. Dr. Priya Verma did her BDS and MDS from prestigious A.B. Shetty Memorial Institute of Dental Sciences, Mangalore. She's a fellow of Perry Fawcett Academy, and she has certification in nitrous oxide inhalation sedation. She's received her PhD from A.B. Shetty Institute of Dental Sciences, Mangalore in 2018, and she's certified in special care and developmental dentistry from Cambridge Institute of Global Health, Kentucky. Dr. Priya Verma is on the editorial board of various journals, and she's editor-in-chief of Society of Bulletin for South Asian Association of Pediatric Dentistry, editor-in-chief for Dental Sciences, J.P. Beathers medical publication, and she has various awards to her credit. To name a few, she received the Best Specialist Award in the category of Special Care Dentist in 2020 in Mumbai, received Editor's Choice Award in the category of Pediatric Dentist by the Guidance Dental Academic Excellence Award in 2019. She received Best Specialist Award in the category of Pediatric Dentist by International Association of Dental Students in New Delhi. These are a few of the awards, and she has got a huge list to her credit. She has contributed to more than 30 books and has numerous publications also to her credit. And academically, her passion is to take care of the special needs of these children. And I welcome you, Dr. Priya, and the session is all yours.
Thank you, Dr. Manish, for a wonderful introduction. And let me just start this screen share. Yeah. Is it all good?
Yes, all well, all well.
Yeah, so I
You can
hope
go
you
ahead.
can see the screen well. Yeah.
Yeah, it is fine.
Okay, so thank you, Dr. Puja, for the wonderful insight. I'm sure you've bridged the gap between the epilepsy knowledge amongst the dentists, because we do read about epilepsy, but we rarely get to see the seizures. And differentiating the types of seizure is altogether a bigger task. So thank you for clearing that out to us. And you have pretty much taken care of everything. And I will cut straight through the dental management without wasting much time. So I'll be talking on the epilepsy and the dental management. So yeah, before I start talking about the dental management, I would like to share this case with you. This is a case of this is a brain spect of a 7-year-old child with a history of seizures, and I just wanted to show how an epileptic brain, a focal seizure looks like in the scans. So this is basically a scan of an interictal brain. The child is having a history of multiple seizures at one go, and this is the phase. This is the scan of interictal brain between. That is the scan of brain between the two seizures. So here, if we see, if you see this golden marked area, just a moment. If you see these areas, this one, you can see how well marked the perfusion of a nuclear scan is. This is a completely normal scan. This is a child with a history of seizure, but currently during the scan, the seizure was not present. The scan is between the two seizures. So here you can see how well the nuclear isotope has taken up, the brain has taken up, and the vascularity is very good. And if I go to the next scan, so this is a scan of an ictal brain. So here the child, the nuclear isotope is injected in the child's vein as soon as the seizure is started. And then basically because of high vascularity, the isotope gets locked in that particular area. It's taken up in that particular area because of the high vascularity. So then once the child finishes going through the seizure, the scan is done. And if you see in this picture, this is the hotspot, which you can see. This is the temporoparietal scan. This is a temporoparietal area, and you can see it's a focalized focal seizure. And you can see how nicely you can appreciate the hotspot. This is the lesion, which you can see, which this looks like. So basically, I just wanted to show you how the lesion, the hotspot looks like in the brain scan, just for the better understanding. So in this presentation, I only aim to achieve one thing: how to go through an uneventful appointment, how to take the child through the dental appointment without having an emergency. Well, we can't avoid it all the time, but we can try. We can try our level best by taking all the precautions. So I'll be talking about this dental management in two parts. That is the pre-operative management. Before we let the child hop onto our dental chair, this is when the child enters the dental setting. What are the precautions we can take? And once the child is on the dental chair, after taking all the precautions and emergencies, and after taking all the precautions, just in case child develops a seizure on the dental chair, what should be the protocol we should be following? Yeah. So we all know that seizures are triggered. So we need to avoid these triggers clearly. When the child is entering the operatory, the child is walking walking in a new place, and dental operatory is already a phobic place for all these kids. Even as a normal individual, when we walk into a dental operatory, most of the patients and most of the children are phobic. You know, so there's no reason for these children so not to be scared and fearful about. So avoiding triggers, clearly the triggers could be stress. Then we need to find out if the child is having seizures at any particular time of the day. If that is the case, we need to give an appointment during the other time. Flashing or the flickering lights, this is one of the most common trigger point on the dental chair. The dental chair light is known as a very common trigger. Then certain foods, maybe which are highly aromatic or which contains high amount of caffeine, any drug usage. Then there are certain patterns, the psychological factors which revolve around the child, not eating well, having the hypoglycemia, being sleep deprived, having some sort of infection or fever, having hormonal changes, or having the having an appointment around the menstrual cycle, or any other over-the-counter medication. So these are the general triggers which we need to avoid. Besides these, there are some dental triggers which also we need to avoid, and stress and anxiety takes the first place in that list. Another one could be dental pain or dental infection, which could trigger the seizure, or any sort of apprehension. So while we manage the behavior of a child in dental office, the first step is to record the complete history, the seizure history. It is very important to know the seizure history of the patient, because that will give you quite a bit of an idea that what type of, at what time of the day the seizure occurs, what are the type of seizures, what is the intensity of seizures, and what triggers the seizure. All that, if we have a history before, management becomes quite simple. So you can also check with the patient if he is carrying any diary or any journal where they note down everything, where they have timed the seizure, or where they have, kept a record of how long and what is the intensity, what is the type of seizure, what are the activities, and what is the patient's behavior post seizure. If you have that dental journal, if you have the journal in your hand, or if you have the diary in your hand, the history becomes quite handy. So these are a few questions that we ask the patients from: since how long you have been diagnosed with epilepsy, what are the triggers. Generally the patient would know the trigger, and they would also know, you need to check with them whether they can, whether they realize whether the trigger, whether the seizure is about to happen or not. Most of the time the answer is yes. They would know. Until and unless the children are really, really small, they cannot really say, but otherwise a grown-up individual will be able to tell you if the seizure, they know the seizure is about to start. How do you maintain a seizure diary? What is the frequency of seizure? So if you know the frequency of seizure, you will also be able to conclude whether the epilepsy is controlled or is uncontrolled, and if it is, and check for the history of the medication. If the patient is taking regular medication, if the medication have been changed frequently. So if you know the medication have been changed frequently, you will also know that the seizure history is of pretty uncontrolled nature. That's why the medicines have been changed frequently. So another question which you can ask is, do you come to know when you're about to get the seizure? Most of the times, if the individuals are independent, they will let you know. What medications are you taking to control your seizure? Are you able to talk during the seizure? That if they are able to communicate during the seizure, that will tell you the intensity of the seizure, that you do not expect a very high intensity seizure if the communication is being made to you. Does the seizure involve the whole body or just a part of the body? So that will also tell you that what is the type of seizure the child, the patient is getting, and if they remember the events after the occurrence of seizure. And so this question will tell you about their post-ictal phase behavior. How do they behave? Are they confused? Are they oriented? And this helps you plan your dental appointment better. You know that someone has to be accompanied. This patient cannot be unaccompanied if the post-ictal behavior is of most of the times it's the patient is confused and would not remember anything. And when was the last seizure activity you had and for how long? So with these questions, and these are very close-ended questions, you will get a very conclusive answers with these questions, and you get quite a bit of information handy. Evaluate the patient on the first visit, that is on the day of appointment. Check the energy levels of the patient, if they're anxious, if they are stressed. Remember, anxiety and stress precipitates seizure. So we need to know on the day of appointment what is the mental status of the patient. If the mental status is not good, if the patient is anxious or stressed, defer doing the appointment, or check with the patient if they have taken the medicine for the day or not. Or you can also get in touch with the pediatric neurologist, and you can check with them and see if any medication has to be given or the appointment should be deferred to another day. So you can also ask them if they have missed their medicine for the day. The next question should be, have you been taking your medicines regularly? If not so, it's not a very good idea to continue with the patient. Have you been taking any other medications except the prescribed ones? So if the patient is dull and gloomy, maybe the patient is on some other psychiatric medication. So please check for that. Do you have check for the anxiety levels again? Do you feel tired, fatigue at the moment? And take it in detail. Has there been any other illness or any other comorbidity apart from the history of epilepsy? Please take a note of that, because that will also tell you if the patient is on any other medication, and it can eventually lead to drug interactions, drug interactions could be really unpleasant. Look for the triggers and avoid violating them. So take the drug history, take a drug history that is in a very detailed format. List all the medications that the patient has been taking, including any change of medication in the recent time and the frequency of medication. This will give you the information about, as I already mentioned, how controlled the seizure are and how frequently the change of medicines is happening, which indicates that what are the types of seizure, whether they are controlled seizure or whether they are uncontrolled seizure. See, Dr. Puja already mentioned that there is epilepsy cannot be cured. It's only resolved epilepsy. So, but seizure can be controlled. Once we know the trigger points, once we know what is the patient history like, the seizures can be pretty much controlled. Maybe with the medication, maybe with the help of the pediatric neurologist, or maybe by making the patient more comfortable, or by deferring the appointment and taking it slowly by introducing the dental home concept, or by sensitizing the patient slowly. It's not really, it's not a golden rule that if you've called the patient to the operatory, you have to treat them at that very appointment. You can go slow. In fact, it's better to go slow. You can make them orient to your operatory, to the people, to the environment around, and they'll be much more relaxed when they come next time. So last of all, list all the side effects and drug interactions on the prescribed drugs. Make a note of it, and so that we don't go wrong while medicating the child. So what is not a seizure? Most of the time, when the patient comes to us in the dental operatory, 90 to 95% of the time, the patient is diagnosed with epilepsy. There are chances you might have a walk-in patient or something, and you miss the history, or the history has not been given to you very well. And there is a sudden, you see an epilepsy-like pattern, but then you need to differentiate it on your own, because here you do not have a diagnosis in your hand, and it's not the pre-evaluated case. So this is a very nice picture. I found it somewhere. I may be shaking. It's a cartoon of Elvis Presley, and he says, I may be shaking, but it ain't a seizure. So everything that shakes in your operatory, or a patient that shakes or mimics epileptic seizure, it's not a seizure. We need to differentiate it. Sometimes it could be syncope, which is characterized by a loss of consciousness. Syncope is something that we are not very new to. We've been handling this right from the beginning because that's the most common dental emergency which we see in our offices. So I'm sure it's not difficult to differentiate the syncope. It's characterized by loss of consciousness without any premonitory signs and symptoms, and it can mimic a seizure sometimes. Migraine headaches, stroke or transient ischemic attacks. And then there are some non-epileptic psychogenic events. They are also known as pseudoseizures. So they are seen in association with some underlying psychiatric conditions such as conversion disorder, anxiety, or depression. So this is a table which describes how do you differentiate between a pseudoseizure, a panic attack, a syncope, and a true epileptic seizure. So a true epileptic seizure is the precipitant, the trigger factor is generally not very obvious until and unless we are we have taken a specific training in recognizing the seizure. It would not be very obvious to you. The duration would be 1 to 3 minutes, and generalized tonic clonic movements have been seen, and moving towards the larger movements, and along with the rigidity. They are pretty much characterized by monotonous epileptic cry. Now this is, I'm sure you all would be knowing what epileptic cry is, but just to give you a heads up, epileptic cry is, when the muscles of the chest, they compress, and in a tonic phase, they compress and the air is pushed through the vocal cords, and you can hear a cry-like of sound. The patient does not actually cry, it's just he's going through a seizure. So that's the epileptic cry for you. And the injuries are very common, especially injuries can be seen in the head and neck area, where the pseudoseizure is an obvious emotional precipitant, and it could be an anxiety attack. It's longer in a duration, 10 to 15 minutes, it may be just non-synchronous, out of the face movements. The patient might be weeping, crying, screaming, and all sort of emotional things you can see happening to the patients. And self-protection is seen before falling. The patient won't be falling unalarmed. Panic attack occurs suddenly without any precipitant, and it is of very, very short duration. You can see it with trembling, sweating, and the fear of immediate death. And it's very uncommon, and seldom it occurs. And syncope is again, it happens due to the emotional precipitant or sudden pain which you feel during the operative procedure. And, it lasts a few seconds. And again, the injury is very uncommon. So, there are certain dental considerations for treating an epileptic patient. The first thing is trauma. So most of the time when the child is going through the generalized seizures and the tonic-clonic seizures, there are often, minor oral surgeries such as tongue biting, lip biting, and cheek biting, along with some other tooth injuries, and there's increased risk of tooth fracture. You can see over here in this picture also, the patient's anterior tooth are damaged, and there's a risk of fracture because of enzyme-inducing anti-epileptic drugs, that's phenytoin or phenobarbital or carbamazepine, because they alter the metabolism and clearance of vitamin D, and the patients in a long term have been associated with the diagnosis of osteopenia and osteomalacia. Another reason for increased fracture is is when the patient is on medicines like benzodiazepines or antidepressants and antipsychotics. Because of the change in the gait, the patient tends to fall, and there is an increased fracture risk that has been associated with these medicines. So trauma is very common whenever there is a seizure or an epileptic attack, and the patient tends to bite their own tongue or cheek and tend to fracture their tooth. Second consideration while treating these patients are the periodontal problems that occur due to. So the studies have said that the overall oral hygiene index and the periodontal issues and gingivitis is very high in patients on anti-epileptic drugs. The Phenytoin has a very common oral manifestation of gingival hyperplasia, which generally occurs after the initiation of 1 to 2 years of treatment. And Phenytoin is a very old drug. Despite having newer medications which have lesser oral manifestations, Phenytoin still is a drug of choice and is being used most commonly. Another set of drug is valproic acid and carbamazepine. They also demonstrate some amount of gingival hyperplasia, and the most common areas that are affected are anterior labial surface of the maxillary and the mandibular gingiva, as you can see in these pictures. The preferred treatment is, I would say, is the substitution of the medicine. Well, if that can't happen, maintenance of the oral hygiene is again an optimal method. Chlorhexidine wash, the fluoric acid rinses, or using both in combination, good oral hygiene. And if the things go really out of hands, the surgical treatment can also be done, but then it comes back. So the best thing would be the substitution of the medicine and maintaining the oral hygiene, as a lot of studies have strongly associated a good oral hygiene with less of gingival hyperplasia. These are some pictures, few pictures of the patients where you can see the hyperplasia in the posterior region and the anterior region. So carbamazepine has other few side effects as well, such as xerostomia, stomatitis, ulcerations, glossitis. Lamotrigine exhibit rashes that may involve the oral cavity, and when we say rashes, lamotrigine is the rashes can be commonly diagnosed as Stevens-Johnson syndrome, which has a very good amount of oral manifestations. You can see the lesions on tongue, lip, most commonly on tongue and lip, and areas involving the buccal mucosa. Valproic acid has a side effect of bone marrow suppression, so it basically impairs the wound healing and the post-operative bleeding and infections due to the decreased platelet count. And this is the most common, well-known, established hematologic effect. In that case, if the patient is on valproic acid, avoid aspirin. Bleeding is a potential side effect if the patient is on valproic acid, and it should be discussed with the patient in the preparation of the surgery. So in case the patient has to go for the surgery, this has to be discussed in detail, the bleeding aspect, because it directly has a bone marrow suppression and impairs the wound healing, and decreased platelet count, of course, impairs the bleeding capacity. So if the patient has to go through elective procedures, please assess the risk of the peri and the post-operative bleeding, and a thorough lab investigations like prothrombin time, bleeding time, prothrombin time, 1 Willebrand factor, everything has to be evaluated. Another aspect of treating epileptic patients, the dental aspect, is the prosthodontic decisions could be very challenging whenever we are, because most of the time when the patient is going through an epileptic attack, the most damage happens is of the tooth. There are inadvertent fractures, and which cannot be saved and may need to be pulled out at some point in time. So you will find these children or these patients with a lot of missing teeth, and the missing tooth should not be left alone. I strongly recommend the replacement of missing tooth, because when there is a space that is generated in the oral cavity and there's a seizure, so the tongue might move into the space and there would be again another set of injuries to the patient. So obviously the replacement has to be, the replacement of the missing tooth comes with the dental prosthesis. So choices should be made that how a dental prosthesis is given. Generally, in normal situation, the prosthesis is of acrylic, which when we place it in, if we try to place the normal denture in an epileptic patient, it might fracture during an attack, during a seizure attack. That denture itself might get fractured or damaged, or some piece of the acrylic the patient might aspirate. So to avoid all that, we need a metal-based dentures or a telescopic dentures. Telescopic dentures is not a very common name, so I'll just briefly give you a heads up what is telescopic dentures. These are called as telescopic dentures. Here there are two copings, one on the teeth, a metal coping on the teeth, and these crowns, the crowns which are made as a single unit, they are hollow and they have a coping over here as well, and this is placed onto the tooth. The reason why these dentures are preferred: A, they are flexible; B, they offer better retention, they do not get dislodged during an epileptic attack, and C, it helps the teeth retaining its strength. The teeth does not get fractured because they are covered and protected with the metal coping around the tooth. So this is a treatment of choice in case the dentures have to be given to an epileptic patient. The telescopic dentures should be considered. If one must prefer fixed prostheses to removable prostheses with the additional number of abutments, so that the strength of the prostheses, the fixed prostheses, can be maintained. Large restoration, whether they are in anterior region or in posterior region, should be avoided as they may fracture during the seizure. If at all FPD has to be given, the FPD should be of metal prosthesis. And if the RPD has to be given, if RPD cannot be avoided, should the RPD be given, please prefer metallic plates or acrylic reinforced with wire mesh and extra support. Anterior crowns, posterior crowns should be given in all metallic, should be in all metallic, and anterior crowns can be given with all metallic with aesthetic veneering or laminates. So another aspect that we need to look into is the drug interactions. Patients with epilepsy are on a lot of drugs, on a lot of medications like AAD and the combinations of therapy most of the times. So when prescribing medicine to them, we need to check with their physician, the treating physician. We can share our piece of information and check with them. And on a general note, the antifungal agents and the antibiotics, in dentistry we prescribe antibiotics, and metronidazole is quite given quite commonly, and metronidazole may interfere with the metabolism of certain anti-epileptic drugs. Again, the co-administration of fluconazole and phenytoin, that is the patient who's already on phenytoin and has been prescribed an antifungal such as fluconazole, is associated with clinically increased plasma phenytoin concentration, and the dose may later require an adjustment to maintain the safe therapeutic concentration. Basically, the phenytoin concentration increases in the blood plasma level, and the drug needs to be adjusted with a pediatric neurologist or a developmental pediatrician, anyone who's seeing the child, so that we maintain the safe therapeutic concentrations. Dr. Puja had just shared one graph with us where she had shown the therapeutic levels, and if you go anywhere above the therapeutic levels, you enter into the toxic phase of the medicine. So that should be clearly avoided. That's why independent prescriptions should not be made. It should be well discussed with the treating physicians, and then a well thought prescription should be given to the patient. Another drug that has been discussed in the literature is sclerothromycin. It increases the plasma concentration of carbamazepine, that again leads to carbamazepine toxicity. So when the clarithromycin has to be given, and if the patient is on carbamazepine, it has to be looked into. Another drug is valproic acid, which may be displaced from the plasma protein and metabolic pathways, and may be inhibited by the high doses of aspirin. So the interaction will free the serum valproate into the concentration, resulting again in the subsequent toxicity. Dental consideration we should have while administering local anesthesia. So local anesthesia, we need to remember, is also a drug, and if it's given, if the administration is done in large quantities, it may induce seizure, and it will induce a tonic-clonic kind of seizure. So although if it is given with a lot of precaution and following the aspiration, and if it is injected slowly in minimal volume of this thing, it will not produce a problem. So lidocaine hydrochloride there's a study done there's a study done in the year 1963, and it's a very interesting study where they've studied the subcortical effects of IV lidocaine and inhalation as anesthetics, and they said the lidocaine hydrochloride, which we use very commonly, has a pro-convulsant and an anti-convulsant effect. So it has an anti-epileptic effect if it is given in low concentration, that is in a concentration of 2 to 3 mg per kg, and this drug is very useful and terminate and can help you take through the status epilepticus. But again, if the drug is given in large volume, I'm talking about the IV administration. So if the drug is given in large volume, and if it is given quickly, it may also lead to CNS toxicity. So local anesthesia should be administered with a lot of precaution. So therefore, we come to a point that we need to do short appointments. Scheduling should be away from the time of seizure. That is, if when you've taken the history, if the patient knows, if there is a general pattern, like the seizure generally occurs during the daytime, or then the scheduling should be done during the evening time. Or if the patient is generally having a seizure during the evening time, then scheduling should be done away from that time. Use of mouth props, because suddenly if the seizure induces, you might encounter an injury, or the patient might encounter an injury by itself in the mouth. So make sure you use mouth props right in the beginning, not allowing the patient to get into an epileptic mode and cause an injury or harm to himself or herself. Make sure that the patient, I am again stressing, make sure that the patient is not anxious and stressed. If this is something we notice, anxious and stressed, we do not go ahead with the dental appointment. We do some counseling, we do some regular x-rays, we just make the appointment little useful and counsel them and send them back to come back to another day much more prepared. Check with the treating physician if you need to give any additional medicine, if these are the general levels of the child and or the patient, and check with the treating physician if you need to give any medication prior to the dental appointment. Avoid situations like stress, that is direct light, that can trigger the seizure. Reinforce the good oral hygiene. Introduce the concept of dental home. I've already mentioned that. Avoid giving large restorations or prosthesis in a patient with uncontrolled seizure, as it may fracture. For gingival hyperplasia, best suitable thing would be substitute the medicine. After discussing, that would be surely done by the treating physician. Discuss it with them, get the medicine substituted, or consider surgical treatment. In a medically controlled epilepsy, consider undertaking the treatment under inhalation and sedation, because inhalation sedation alleviates the stress and anxiety. So if the child has a history of controlled epilepsy, inhalation sedation is the best way to treat the child. It not only takes away the stress and anxiety, it makes them go through the procedure smoothly. but with a word of caution. It's not contraindicated, but everything needs to be used with the word of caution. Nitrous oxide should not be given in acute head trauma. Acute head trauma, the nitrous oxide should be avoided. Another thing which we need to avoid is hypoxia. The hypoxic event needs to be avoided. So one has to take care that before starting with the sedation, we need to give 100% oxygen for 5 minutes and saturate the body with oxygen. And once we finish the procedure, we need to again give 100% oxygen for 5 minutes, and so that we can avoid any hypoxic events. Nitrous oxide is also not known as an epileptogenic agent, so it is not known to induce the seizure. In the case of controlled seizure, you can undertake the case in a dental operatory, and in the case of absolute uncontrolled seizure, consider treating the child under the hospital settings or under general anesthesia. These were the few measures that we could take before letting the child hop onto the dental chair. After taking all the precautions and after doing our level best, there is a possibility that we still might land into the emergency management, and certainly we should know how to deal with it should this happen. So before we treat any special case or any epileptic case, yes, I would highly recommend that we should have emergency medicines, oxygen, pulse oximeter, and we should have devices to measure the vitals. And this is really mandatory because as dentists, we are not commonly equipped to handle these emergencies. We do not really have this every day, but we need to just have it once, and we had it. So you do not want to be in a situation where you are feeling sorry about yourself or the patients. So these are a few list of things that I could think of, that is oxygen, aromatic ammonia, aspirin, glucose, nitroglycerin, dexamethasone, atropine, diphenhydramine, epinephrine, naloxone, salbutamol, atropine, ephedrine, diazepam, midazolam, labetalol, pulse oximeter, and BP apparatus. Most of us might have these things, but how often we need it? We don't really need it very often. So once we don't need it very often and you land up in a medical emergency, it's really perplexing. You are not really used to it. You're not really used to it. And to avoid that situation, there are few things that we can do. This is the emergency preparedness checklist, which we can follow, and that can make our job really easy. That is, everyone in the dental office should have specific assigned duties. Suppose we are 3 dentists and there is an emergency, and we know there has to be an emergency bell with which everyone is familiar with. They should know that if the bell is there, there is an emergency, and everyone should run towards that. One person should know that the emergency medicines has to be procured. Another one should be assigned giving duty of procuring the oxygen and placing the mask. And the third person should know that should be alert enough to alert the medical emergency and call in the doctor, or prepare the procedure for shifting the patient into the emergency. So contingency plans are in place in case the staff member is absent. So if in case a staff member is absent, there should be a backup plan that who will take over the duty. Everyone should receive appropriate training in the management. That goes without saying. Everyone should be trained for the basic life support. Any clinic who's doing special care dentistry, or any dentist who's doing special care dentistry, it's their moral duty to know about the basic life support and should be trained well in that area. The dental office should be equipped with the emergency equipment and supplies that are appropriate for that practice. Unannounced emergency drills should be conducted every few months, so that your staff is equipped enough to handle the emergency if it really happens. Emergency telephone numbers should be placed near each phone. Oxygen tanks and oxygen delivery systems should be checked regularly. Emergency medications should be checked monthly, and they should be replaced in case anything is near expiry. All the emergency supplies should be restocked immediately after use, and one staff member should be assigned to quickly review this checklist regularly. Coming to the most important part, status epilepticus. So clinical state, what is status epilepticus? Any seizure lasting for any seizure activity lasting for more than 30 minutes. It can be labeled as a neurological emergency. And the duration is considered to be anything greater than 5 minutes, you can call it status epilepticus. Now, unlike adults, children, status epilepticus is the first presenting feature in children. 80% of the cases occur in the first 5 years of life. So the sequence of the event during the seizures are something like this. There may be brief mourning, there may not be. It's up to the dentist if they can really take up the clinical sign, or according to their clinical knowledge, if they can really understand the seizure is about to start. That I leave it up to the clinician. Patient may encounter sudden loss of consciousness. They may become rigid. They may fall. They may give an epileptic cry. There may be development of cyanosis. There may be after a brief period of 30 seconds, the jerking may be present. Tongue may be bitten. There may be oral injuries. This is the clonic phase where you can see oral injuries. Frothing of the saliva if the seizure lasts for more than 5 minutes, or if the seizure is rapidly repeated. Loss of bladder control. If the seizure lasts for a few minutes, the patient may become flaccid but remain unconscious. That is, the patient has already entered the postictal phase. The patient continue to remain confused even after regaining consciousness. So management of status epilepticus in a dental office should be clear the instruments immediately in the vicinity to avoid injury. Position the child or the patient to his side to avoid the aspiration or to avoid the falling back of the tongue in order to maintain the airway. Do not try to stop the patient and let them go through the seizure. Loosen up their clothes, but that should be done well within the dignity and maintaining the patient's dignity. You can, take the chair down at the lowest level and give them a restraint so that they can avoid falling on the floor. In case restraint is not there, then you can put the patient on the floor and let them go through the seizure and put them onto the side. Remove all the clear everything around the patient. Time the seizure as it may appear longer than it is. As Dr. Puja has already mentioned, A, B, C. The first thing you have to do is position the patient. I would say P and A, B, C and D. I will come to that later, but initiate the treatment by managing the airway, breathing and circulation, and activate the emergency if the seizure is longer than 3 minutes, or if you see the child getting cyanotic. Start administrating oxygen at the rate of 6 to 8 liters per minute. Ensure the safety, check vitals and activate emergency. If the seizure lasts for more than a minute and there is a repeated seizure, give 10 mg of diazepam, IV or IM. Whenever we are doing performing special care dentistry, the basic expectation of giving an IM and IV should be there. The dentist should be in a position, nevertheless, they should be in a position to give an IM or an IV. If the diazepam is not there, give 2 milligram of Ativan, IV or IM, or 5 mg of midazolam, intramuscular or intravenous. Be aware that despite giving all this, there would be a possibility of uncontrolled seizure. That's why we say, even though the medication has been given, please activate the emergency and get in touch with the treating physician. In atypical seizures, injuries are generally prolonged. In that case, call for an ambulance and administer buccal midazolam. If you can't do anything, please administer buccal midazolam. Dr. Puja discussed it about the nasal midazolam and how it has to be given. And You can also do buccal midazolam, which is available in the brand name of Epistatus according to the body weight. And this is the dosage which you can give in children over 10 years, 1 ml, that constitutes 10 mg of drug. For children between 6 to 12 months, 0.25, 1 to 4 years, 5 ml, and 5 to 10 years, 0.75 ml. Once the seizure is over, please do not think of taking back patient to the dental chair. Do not undertake any dental procedure. Place the patient in a recovery position. Talk to the patient, evaluate the level of consciousness in the postictal phase. Do not restrain, as the patient may be confused at that point as they don't remember anything what they have gone through. Do not let the patient leave the operatory until the full consciousness is achieved. Do a comprehensive dental checkup for the sustained injuries. This is very, very important every time, even for a dentist and for a pediatric neurologist or a treating physician, to know that every time a severe seizure or an epileptic attack is there, please send them back for the dental checkup, because there might be injuries that would have taken place and they would require attention. And you know, there might be some irreversible changes, or if the injuries are small or they later become big after some time just due to ignorance. Discharge the patient with someone responsible. This is, I'm just sharing this thing with you. There are 3 phases. The management of convulsive status epilepticus in a very short form. Prodromal phase, where you can recognize the aura, ictal phase, and postictal phase. So activated, once you see if you can recognize the aura, please discontinue the dental treatment. As the patient enters the ictal phase, activate the emergency treatment. Position the patient in supine position with feet elevated, that is Juvenile birth position. Consider activating the emergency medical surfaces again if you haven't done so before. Check for the circulation, check for the airway, and check for the breathing. Assess and perform a basic life support and give a definitive care, that is protect the patient from the injury. If seizure persists for more than 5 minutes, again reassess and check the circulation, airway, and breathing. If perform given IV diazepam or a nasal or a buccal midazolam. So I would like to just conclude this talk by saying that understanding a neurological process allows, as a dentist, allows us to understand and manage patients better in our dental chair. People with epilepsy can be safely treated in a general dental practice, although a good medical history should be taken and updated at each visit, and that can make our job much more easier. The seizure history should always be taken into account when planning the treatment. Thank you.
Thank you, Dr. Priya, for a wonderful insight into the management of an epileptic patient in dental setup. I'll hand over to Dr. Alves for the question answer session.
All right, thank you, Dr. Puja and Dr. Priya. Kindly note that some of the questions have already been answered and are available, and you are able to view them in the question and answer session section in your various software, whether it's web or an application on your tablet or phone. However, we have some questions that arose during the presentation by Dr. Priya, and Dr. Puja has been gracious to save some time and answer her questions already. I will only raise one that I have seen that has come up on Facebook for you, Dr. Puja, if I can allow you to start with this one. There's a question here by Jyoti Isaac. Ethoxyzumide is still the drug of choice for petit mal. Is ethoxyzumide still the drug of choice for petit mal seizure?
Yes.
Dr. Puja.
Yes, petit mal seizure, also called as absence seizure. So the drug of choice is ethoxyzumide only. So previously, a year back, it was not available in India. So we used to give Valparin or levetiracetam, but now it is easily available in India. So, and that is the drug of choice for petit mal or absence epilepsy, whatever you want to say.
All right. Some of the questions, thank you, Dr. Puja. Some of the questions that were being asked in the chat section, I might miss. So kindly repost in the question and answer section. I will start with those ones in the question and answer session. Most of this are for Dr. Priya, as Dr. Puja has answered hers already. We'll start with Mogit Gupta. In a patient with a history of epilepsy, which is a better way to meet their dental needs, conscious sedation or general anesthesia?
Sorry, please come again.
In a patient with a history of epilepsy, which is a better way to meet their dental needs? Conscious sedation, general anesthesia?
If I did mention, if the patient is having controlled epilepsy, if the epilepsy is controlled and there are no frequent seizures, if it's medically controlled, the patient can be taken under inhalation sedation procedure. But if the patient is having uncontrolled epilepsy and the treatment is mandatory, it's better to take up the case under general anesthesia.
Okay, thank you very much. Then there's one here I don't quite understand, about certification. I don't know if that is to do with the presentation attendance. How does folic acid help in regression of hyperplastic gingiva? Dr. Priya?
Well, folic acid does not help in the regression. It just supports. It's a folic acid. These are the mouthwashes which were suggested, so that it helps you maintain the oral hygiene and tries to take back, regress the gingival hyperplasia.
So basically, I would like to add in this that there are certain anti-epileptics which work on the folate metabolism and which inhibits the production of folate and for the absorption too. And because of that, you can have a lack in the folic acid level in the blood, and specifically for Phenytoin, which causes this concern and leading to this gingival hyperplasia. So if you just give an amount of folic acid and increase the amount, then maybe, I'm not sure of, but I know the mechanism by which this produces. This is definitely by the non-absorption and inhibition in the pathway of folate metabolism, which causes this gingival hyperplasia. So I don't know whether increasing the amount of folic acid in the diet would help or not, or just stopping the medication would be the better advice. I'm not sure.
Right, thank you.
Substitution of the medicine would be a better advice, because they go to, most of the time they are on couple of anti-epileptic drugs. So I think substitution would make a better sense, because and maintaining the oral hygiene, because we cannot be doing the procedures again and again. The surgical procedures for taking care of the gingival enlargement. I think substitution would be the first choice, along with maintenance of the oral hygiene. The personal hygiene should be preferably maintained.
Okay, thank you. From Umi Salma, does the sound of air rot trigger seizures? If yes, what are the other options for restoring teeth?
The sound of air rotor definitely baffles anyone, not only the epileptic children. And in the case of epilepsy, it's only you can really assure that it can only increase when we are taking care of children with special care needs. Our treatment modalities has to be modified. We cannot treat everyone the same way. We cannot be using drills, which is the way we regularly treat patients. We should modify our techniques to, using less of drills, using STF rather than doing big restorations. We have to also think in terms of doing atraumatic restorative procedures. And then as I already said, we cannot be doing big restorations, because they will anyways land into the fracture. So we have to cover it up with the crown. Now with crown also you need drills. So what is the best way of dealing? Hall's technique, I think, is a very good method of dealing with, non-drill crowns and restorations. STF and Hall's technique is a very good technique which we have handy, and we don't have to, I mean, even in COVID times, where we were supposed to perform non-aerosol dentistry, we have been performing a lot of STF and Hall's technique, just by avoiding drills.
Okay, thank you for that. Maybe a related question from an anonymous attendee. How will large restoration fracture during seizure?
How will a large fracture? Because most of the time there are oral injuries, and you are in the tonic clonic phase, you are expecting the jaw activities, and it's a very common feature for the, the large restorations are unstable, and we most of the time when we talk about large restorations in the normal scenario also, we tell the patients that the large restorations generally fail. It's better to top it up with the crown for the safety purposes. And I think, yeah, that's pretty much the reason, the oral injuries.
Okay. Yeah, then there is another one here by anonymous attendee. Can you explain what do you mean by seizure freedom and breakthrough seizure?
That for me?
Dr. Puja, please.
Already explained, like, what do you mean by resolved epilepsy? So once you have no seizure for 10 years and not having an anti-epileptic for 5 years, that's called as resolved epilepsy. That means you are free of epilepsy. Whereas a breakthrough is like, even after resolved epilepsy, if you have labeled it as resolved, you can still have a chance of having a breakthrough seizure. Or once you are in a period of having a seizure freedom for next 10 years, in between, if you get a seizure, that also is called as breakthrough seizure. Breakthrough is like any time, any point of time. The more the number of years you have passed without seizure, there is lesser the chance of having a breakthrough seizure. If you have like no seizures for 10 years, the breakthrough chances of having a breakthrough seizures decreases very dramatically. So that's the difference. That's all that I have to say.
All right,
I also
thank you, Doctor.
want to add one point, because I answered like only in the tidbits. There was one question which somebody asked, like, when are you using carbamazepine? It is dose-related Stevens-Johnson syndrome. So I would like to tell you that if you will see in the insert which is there present in the medication of carbamazepine, you will see that every Asian population has to go through a genetic testing which is called as HLA 1502. Which is against, which is like passed through the government of India too, that before prescribing, you have to do this HLA typing, because Asian population has a very high susceptibility risk of having reactions to carbamazepine leading to Stevens-Johnson. But we as an pediatric neurologist forum have decided not to do this test, because that's like very costly, and also it's done in very few centers at India. So we are prescribing without doing this testing, but with every time we write this prescription of carbamazepine, we have to write down that we have explained the risk of having a rash and Stevens-Johnson, just to get out from the medical legal complications later on. So with the smallest dose also, you can have Stevens-Johnson. Make sure that with every prescription, you should explain the risk of having Stevens-Johnson once you are writing carbamazepine.
Okay, all right. Thank you for that clarification, Dr. Puja. Are there any signs that we while treating them? Asking out of curiosity.
Sorry, your voice was breaking. I could not hear.
Are there any signs we can eye for which might be developing a seizure episode while treating them? Asking out of curiosity.
No, I'm not still, I'm not
No,
able to.
what he's trying to ask is, while treating a patient on a dental chair, are there any signs that we can pick up that we know that the child is about to enter a seizure? Is there any signs that we can pick up?
Yes, yes. You already have described, Dr. Priya, that there's something called as aura.
Yes.
So a patient who's very well stable on your dental chair will become a bit uneasy, or will start taking out its clothes, or will some start doing, you can see the unrest on the face. And if you will go and ask for the history, so before taking it on the dental chair, always ask the history whether the child has any aura before the seizure, because aura is a premonitory symptom where you can get to know about that the seizure is just coming in. So aura could be like anything. The child will complain, I'm getting retching in the stomach. That is the most commonest aura for a temporal lobe epilepsy. The child would just start moving his head, or start just pulling up his hair or clothes. So that could be a symptom of aura, and that could be the sign. You take the history, stop the procedure, ask for the history again, and get all your equipment ready for a seizure to happen.
Right. I think I'll just pick one question here from the chat section, where Philip Ogordi from I think Nigeria is asking, are you using the IV midazolam via the nasal as an intranasal, Dr. Puja?
So you can use, but the only problem is it has to be used by an atomizer. That means because the intravenous is for veins, so once you have to put it the same solution in the nostril or the buccal mucosa, it has to be atomatized. Without that, the absorption is not good. That is why we don't prescribe intravenous usage, the intravenous midazolam to be used as in the buccal or intranasal, because without the automatization of the thing into a spray form, the absorption is not good, and because of that the results are not that great.
Okay, thank you very much for, I think that is it for questions. I will now hand back to Dr. Manesh for a vote of thanks. I think there's a comment in the question and answer session where someone is giving a comment where you can, which relates to your segment. Dr. Manesh.
Asking about the CME hours does the lecture have, and is the certificate will send to your emails. Dr. Priya, any update on certificates, or it's only for the
certificates will be issued by KAPD. If they are a registered attendee, this attendee looks like a Facebook attendee, I think. For Facebook, I doubt there is any appreciation certificate. Am I right, Dr. Elvis?
Yeah, that's correct.
Yeah. So this attendee doesn't sound to be a registered attendee, so I regret that we will be able to provide any certification for this.
Okay. For those who registered, their profiles will be automatically updated with the points, so not to worry, especially the Kenyan ones. Dr. Manesh, please carry on.
Yeah, thank you so much. Thank you, Dr. Puja, for simplifying the classification so that, that accordingly the treatment could be rendered. It was a wonderful presentation of making it so simple for the audience to grasp the classification. And thank you, Dr. Priya, for insight into step-by-step insight into how to manage a patient in a dental setup, which is very important. Most of us are not aware how to handle the situation. So hopefully this is going to enlighten them, and they will take some positive points from your presentation. Thank you one and all, and thank you Dr. Elvis and Dr. Kerr for all the bonding and association which we have developed, and hopefully will progress in a more positive way in upcoming webinars. Thank you one and all.
Thank you.
Thank you, sir. Thank you for having us over.
Thank you. Thank you all for the good presentation, and have a lovely evening. Good night.
Thank you so much. Stay safe and stay healthy.
All right. Thank you. All this is recorded and available for viewing offline, but with no CPD points. Thank you and goodbye.